Good evening, everyone, and welcome to the EUROGEN webinar programme. Just before we get started, I'd like to take a couple of minutes to explain a little bit about what EUROGEN is and does. So EUROGEN is one of 24 European reference networks created by the European Commission in 2017. And we're currently a network of 56 healthcare providers providing highly specialised surgical care to patients with a rare or complex disease, and we're covering 20 member states. So the aim is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urogenital diseases and complex conditions who all need highly specialised surgery, so where the expertise is rare. So some of our activities, as I hope you noticed from the slide at the beginning, is we're able to deliver virtual consultations using a secure IT platform provided by the European Commission, which allows us to conduct cross-border MDTs. So teams of our experts can help diagnose, suggest treatments or surgical approaches. So please, I strongly encourage you, if you have a tricky case, please don't hesitate to get in touch with our network. And this service is completely free for all healthcare professionals in the European Union. We also conduct training activities like this webinar series. We work together on producing clinical guidelines for the rare and complex conditions, along with the scientific societies as far as possible. We're also collaborating, setting up a patient registry, which is currently being rolled out across all our healthcare providers. And finally, I'm really excited to announce that we are publishing a book very soon by Elsevier, which will be out shortly, and that's on rare and complex urology. So I would strongly encourage you to have a look at that. It's announced on our website also. So without further ado, the webinar this evening will be presented by Dr. Arnout Alberts, who is a urologist at Erasmus University Medical Center in Rotterdam in the Netherlands, which is one of our healthcare provider members. And his specific area of interest is oncological urology in testicular cancer. And we hope that Assistant Professor Talita Zuveloon will join us, and she's also working as a urologist at Erasmus UMC, and we hope she'll join the discussion at the end. So the topic of this evening's webinar is retroperitoneal lymph node dissection for testicular germ cell tumors, and as you'll know, this is highly complex surgery and should be performed in high volume centres. This type of surgery requires meticulous planning to obtain the best oncological and functional results. And 3D virtual reality imaging can also now help to improve the surgical planning by the urologist. So this presentation, we're very, very grateful to Arnout with your expertise. He's going to elaborate on the surgical pathway and the implementation of 3D virtual reality in retroperitoneal lymph node dissection surgery. And just to know that this webinar is CCME accredited for live attendees. So if you fill in the form at the end of the webinar, you can get the CME points. Thank you very much, and I hope you enjoy it. Arnout, you have the floor.
Thank you, Michelle, for this introduction. I hope everybody can see my screen right now.
Yes, it's visible.
Good evening to you all. Thank you for joining this webinar. Michelle already did the introduction, which was very meticulous. So, as she said, together with Talita Zuveloon, we do the RPLND surgery at Erasmus MC, and that was what this talk is about. I have no specific conflict of interest to declare. So testicular germ cell tumors are a rare form of cancer. Nevertheless, it is the most frequent solid cancer in young men. And only a subset of testicular germ cell tumor patients will need this retroperitoneal lymph node dissection surgery. In the Netherlands, less than 100 RPLND cases are performed per year. So this means that there's relatively low volume per center for this surgery. Nevertheless, this is complex surgery due to the adhesiveness of tumors to blood vessels and organs. Therefore, RPLND is associated with major complications as described in literature in 5 to no less than 30% of cases, meaning morbidity for the patients and an impact on the quality of life. The lymph node dissection is performed according to a standard template, the modified unilateral template. Sometimes, in case of bilateral bulky disease, we perform a bilateral template dissection. These templates are marked with the anatomical landmarks that are the large vessels, the renal vessels, the ureters, and the iliac vessels. Indications for RPLND are therefore chemo-naive patients, primary RPLND we call that, specifically in clinically stage 2 disease, non-seminal metastasis, where there are negative markers. But there's increasing evidence through recent trials also for the indication in stage 2 seminoma germ cell tumors. Actually, we are currently starting with a second trial, that is the PRIME-TEST 2 trial, together with our partner, the University Clinic of Düsseldorf, which is also a participating center in eUROGEN. More frequently, we perform RPLND in post-chemotherapy cases, in case of a residual mass larger than 1 centimeter for non-seminal metastasis, or less frequently in case of residual mass above 3 centimeters for seminoma germ cell tumors. And any residual tumor mass present on the imaging after salvage chemotherapy. Complications associated with RPLND are vascular lesion, usually of the aorta, cava, renal vessels, or the lumbar vessels, which can lead to major blood loss during the procedure. A lymph leakage can occur, leading to symptomatic lymphoceles in up to 5% of cases, or callus ascites. Urethral lesions are less frequent, and also uncommon are the intestinal lesions, and sometimes we have to sacrifice the inferior mesenteric artery, which can lead to ischemia of the colon, but this is also uncommon. Pancreatic lesions can occur if we perform a resection of masses above the renal vessels or in the retrocrural area. And also incomplete metastasis removal can occur, specifically if the procedure has to be aborted prematurely, for example, in case of a major bleeding. And we see in the post-chemotherapy cases approximately 5% of retroperitoneal recurrences. Complications can occur as in most abdominal procedures, such as wound infections, paralytic ileus, pneumonia, and thromboembolic events. The most common impairment caused by RPLND surgery is ejaculation impairment due to sympathetic nerve damage. In case we perform a full nerve sparing procedure, we only see ejaculation impairment in less than 10% of cases. But if we perform the standard modified unilateral template dissection, to 15% of patients have ejaculation impairment postoperatively, and bilateral non-nerve sparing procedure can lead to ejaculation impairment in up to 75% of patients. Adjunctive procedures during the RPLND surgery has been described in 25% of cases in case of post-chemotherapy RPLND. The nephrectomy being the most frequent adjunctive procedure, which can be performed in case of renal vessel invasion or in case of a functional hydronephrotic kidney. Vascular resection sometimes has to be performed, which can also need reconstruction with a patch or interponate. The aortic involvement needing replacement is very infrequent, but more frequently caval vein involvement is present, needing a resection of the caval vein, which we can often ligate, but sometimes have to put in a prosthesis as well. Less frequently, a wedge resection of liver lesions needs to be performed, or a vertebral resection in case of involvement of the spine. The risk of RPLND related complications and adjunctive procedures is increased in case of post-chemotherapy surgery, in case of redo procedures, and when we need to perform salvage desperation surgery in particular, or in case of bulky disease, encasing large vessels or organs, or when suprahilar or retroperitoneal masses are present. Obviously, it's crucial to minimize RPLND related complications, and we can do this by increasing our surgical experience. As I've said, in the Netherlands, at least the volume per center is already relatively low, and therefore it is vital to centralize the cases, in particular the redo and the salvage cases, so we increase the volume per center and per surgeon. And obviously knowledge exchange between centers is very welcome, and therefore webinars like these are important, as well as the CPMS case discussions, as Michelle mentioned. And also EUROGEN facilitates clinical visits. As you can see over here, Dr. Yuwache was visiting the university, the Erasmus University, coming from the University Clinic of Düsseldorf, and giving his knowledge, spreading his knowledge in RPLND surgery. Another way to minimize RPLND related complications is to improve the planning of the surgery. Preoperative patient counseling is vital, and particularly on the procedure and the complications associated with the procedure. And at our institution, the preoperative counseling is assisted by our website, which we actually use in the consultation room, and also refer patients to. And this website contains the care pathway of the procedure in our institution, specific patient information on the procedure, with videos as well. Patients receive an information form on the procedure, and apart from the counseling by us urologists, counseling is performed by dedicated specialized nurses, and there are a case manager for the patients during the preoperative and postoperative phase. And we facilitate referral to the HaDEA cancer network for patients. The diagnostic workup consists of conventional imaging. And conventional imaging usually means CT, 4X abdomen, which we perform and repeat if the CT is older than 6 weeks prior to the surgery. Seldomly, we perform PET-CT as well, particularly in case of post-chemotherapy, seminomas, or in the salvage setting. The serum tumor markers are followed prior to surgery and are repeated quite close to the surgery to rule out sudden elevation, which can change the policy. We routinely measure the microRNA 371 pre and post-operatively and during follow-up, just for study purposes. And we do biobanking. We bank blood and tissue of the patients. All patients are discussed in our multidisciplinary tumor board. And only recently we've established the National Tumor Board in the Netherlands, where the complex and salvage RPLND cases are discussed, also to exchange knowledge on the procedure. Not only surgical planning, but also anesthesiology planning is vital for this procedure, and particularly in case of an increased risk of pulmonary toxicity, meaning pulmonary pneumonitis or fibrosis, in case of patients having received 4 cycles or more PEB, older patients and patients with a smoking history or history of renal insufficiency. These patients in particular need preoperative pulmonary function testing, and in the perioperative period, fluid overload should be minimized, and ventilation should be performed rather with just air instead of supplemental oxygen. The surgical plan, it is very important to determine whether if thorax lesions are present, the surgery should be performed first in thorax or in the abdomen, depending on the volume of the disease, and also combined thoraco-abdominal procedures can be performed. The RPLND can either be performed with an open procedure, which is the golden standard, via midline laparotomy, or a robotic minimally invasive procedure. We should establish which template to resect, and it is vital to compare the pre and post-operative, post-chemotherapy imaging when determining this template. Anatomical variations should be recognized, for example, accessory renal arteries, retroaortic veins, and duplicated ureters, not to be surprised during the procedure. And we should anticipate on adjunctive procedures such as the need for a nephrectomy or vascular reconstruction, so surgical colleagues can be standby for these adjunctive procedures. Therefore, it is vital to have a dedicated multidisciplinary team for this type of surgery, not only containing the urologist and the anesthesiologist, but also the vascular surgery, the abdominal hepatic surgeon if liver mobilization is needed or a liver resection should be performed, the thoracic surgeon, as I've already mentioned, as well as the orthopedic surgeon. So the open RPLND is the golden standard procedure. However, robotic RPLND can be performed in selected cases and is associated with less blood loss than the open procedure, as well as a shorter median hospital stay. Patients after robot RPLND usually go home next day at our institution, as compared to within 3 days after the open procedure. We perform the robotic RPLND when possible, but as I've said, strict selection is performed, and Approximately half of the cases are performed robotically at Erasmus. Indications for the robot surgery are primary RPLND, less complex post-chemotherapy RPLND, and unilateral disease specifically. As I will mention, we use the flank position and not the supine position, and stage 2AB disease, meaning that tumors cannot be larger than 5 centimeters. Contraindications for the robotic procedure are bulky disease with tumors over 5 centimeters, dorsal intra-aortic caval tumors specifically that are harder to reach with the robotic procedure, as we don't want to compromise our surgical margins. Large vessel invasion is definitely a contraindication for the robotic surgery, and redo cases we also do open, as well as the salvage surgery procedures. Over here you can see a small periaortic mass, typical case that is eligible for the robotic procedure. And we've recently performed this case. As I've mentioned, we use the flank position, similar to the kidney robotic procedures, but you can also use the supine procedure in Trendelenburg, and then actually can perform a bilateral dissection. As you can see, the port placement is, as we use the XI robot, is in one line, and the incisions are small, meaning the post-operative recovery is usually fast. And this is also a recent case at Erasmus, about a total different case of bulky disease with encasement of the caval vein. And as you can mention, we've performed an open RPLND. Over here you can see the large tumor encasing the caval vein and the surgical field after the resection, and we were actually able to spare the caval vein. And Talita and I were quite pleased. We always do these procedures together, and it's good to do this with 2 urological surgeons instead of 1. So the standard clinical care is the 2D CT scan, conventional imaging. However, the anatomical detail provided by the 2D CT is relatively limited, and this means that sometimes complex relations of tumors with adjacent vessels and organs can be very difficult to evaluate. And this can lead to suboptimal planning of the procedure and unanticipated situations during the surgical procedure, which in turn can lead to complications. And therefore, there's a clinical need to have improved imaging modality. And this was underlined by a questionnaire that we've done in eUROGEN centers. 3D virtual reality planning is a new imaging modality where the 2D CT is reconstructed in a 3D model, and that can be viewed through goggles, giving more anatomical insight on the surgical field. And this 3D virtual reality planning has been evaluated only in a couple of small studies. One study has been performed in partial nephrectomy, where within a small cohort, a reduced operative time was seen, as well as a reduced clamp time, blood loss, and hospital stay, which is promising. In our own institution, the 3D virtual reality planning technique was applied in pulmonary segmentectomies in the thoracic surgery department in a small cohort, leading to a change of plan in no less than 52% of patients and less irradical resections. This led to our idea to apply this technique in RPLND surgery with the hope to reduce complications. Our first step was to develop an AI algorithm to automatically segmentate anatomical structures, as the segmentation by hand is very time consuming. So we've developed an AI algorithm that segments the anatomical structures automatically within the 3D model. And our plan is to train this AI algorithm to improve its accuracy in segmentation using a large data set of 4 Dutch expert centers that are involved in eUROGEN, with a large cohort of 250 RPLND cases. We will perform a prospective RPLND trial applying the 3D virtual reality technique as soon as we have our algorithm constructed in a single arm trial, which is basically a feasibility study, and we will evaluate surgical outcomes such as the ejaculation impairment, blood loss, hospital stay, and compare with a historical cohort. As I've said, 4 Dutch expert centers will be involved that are also associated with the EUROGEN network, that is the Radboud UMC, UMC Utrecht, the Antonie van Leeuwenhoek Dutch Cancer Center, and obviously Erasmus. Future perspectives after this trial are a large European randomized controlled trial within EUROGEN, and a future perspective will be the possibility to perform overlay of the 3D virtual reality images on the surgical field during robotic procedures. Take-home messages of my presentation are that RPLND for testicular germ cell tumors is complex surgery associated with complications and morbidity. Therefore, it is important to centralize to expert centers with a multidisciplinary surgical team. If possible, robotic RPLND can be performed. However, open RPLND remains the gold standard procedure. Meticulous planning of RPLND can help to prevent complications, and new imaging modalities such as 3D virtual reality planning could help to improve surgical planning. Thank you for your attention.
Thank you so much. So if you have any questions, you can type that in the questions field, and I will pass these on. I've received a couple. I am going to pass these on right now. If you could read them out loud so everyone knows what's being asked.
I've received the first question, that is, do you take into account the number of chemotherapy cycles when you select for robotic or laparoscopic approach? And the answer is no. That means 2, 3, 4 cycles of platinum chemotherapy doesn't change our decision to perform an open or robotic procedure. What does is patients having received a salvage chemotherapy scheme. So that means recurrence after the first chemotherapy, having received the second line of chemotherapy. In those cases, we perform an open procedure as to anticipate on potential recurrence and chemo resistance afterwards. Then there's another question. Did you have any mortality after RPLND for testicular cancer? And the answer is basically no. So no mortality during surgery or directly in the first phase after surgery. We did have recurrences quite fast after desperation surgery, leading to mortality, but not during the surgical, due to the surgical procedure itself. Yeah, so in chemotherapy refractory patients, desperate surgery can be performed with value of tumor markers. So yes, the answer is in these cases, surgery is actually the only treatment that can cure. And in these cases, we tend not to look at the specific value of the tumor marker, but rather if we can resect. So an HCG or an AFP that is higher or lower doesn't change our approach, as long as we've got the feeling that we can resect the tumors based on the imaging. Do you have any experience with children? Who performs that? Pediatric surgeons older than 11. I must say that I do not have experience with patients that are that extremely young. The youngest patient that I've operated on was 16 years old. I guess if we would operate on a child, we would be involved together with the pediatric surgeon. But I have not done a case like that.
Yeah, so I can add to that indeed we would involve also the pediatric surgeons for sure in these young patients.
Indeed, but I think it will be a combined effort.
Absolutely.
And then what is the criteria, or how could you select cases for robotic procedure? So as I've said, what is very important is that that it's a unilateral disease. We don't perform robotic procedures in bilateral disease. We have to be confident that we can fully resect the lesions. With intra-aortocaval dorsal lesions, personally, I'm less confident, and normally we opt for the open procedure in these cases, although intra-aortocaval resection can be performed and is performed systematically within a template. The tumors that are dorsally over there, normally we perform the resection open. Most of the primary RPLND cases obviously are performed robotically. Did not mention laparoscopic approach. No robot is more precise, but if not available, is laparoscopic feasible? And the answer is yes. I do not have a personal experience with the conventional laparoscopic approach, but there is experience and it has been well described, so it is possible. However, I think that with the selection of cases, you might be even a bit more strict when opting for conventional laparoscopic procedures, as I can imagine that technically it's less feasible, for example, in the intra-aortocaval region, but it's definitely possible. Experience with IDG, US guided injection in the spermatic remnant. So I do not have personal experience with this approach. We have the XI robots with the Firefly option, so it is something we can use. We use ICG sometimes when we make difficult anastomosis, for example, urethral ileoconduit anastomosis, but a more or less sentinel node procedure with ICG I've never done before. But it could be something interesting to look at. I know that our partner, Dr. Hugo Che in the University Clinic of Düsseldorf, is currently running a trial specifically for this topic called the RAISIN trial, if I'm not mistaken. So any questions can be addressed to him as well. Let me see. For clinical stage 1 cases, non-seminomatous germ cell tumors, for pathological staging, modified RPLND could provide better diagnosis and spare unnecessary chemotherapy. What is your opinion? I agree, although we usually do not tend to do this in our institution. It can be done in selected cases, specifically in cases where you do not want to give chemotherapy due to comorbidity of the patient. So I fully agree, but we don't do a lot of these cases. Not sure if this was answered yet. What is the minimal number of procedures per year for expert center? Yeah, so this is not well defined, but if you're asking me, I would say a minimal number of 20 cases per year, preferably, and that is just my opinion. But ideally, this should be even more, in my opinion.
Great, thank you so much. Those were the questions that came in at the end. So if you have a burning question right now, you can send it in and I will pass these on. If not, I would like to take this moment to mention that the webinar has been recorded and will be available on both our GoToWebinar platform and the YouTube channel. I will be sending the links to everyone tomorrow, so you can watch it back. You can also subscribe to our YouTube channel. There are all the past webinars are on there as well. And finally, I would like to mention that there will be a survey sent to the attendees who have attended live this evening. And if you could fill that in, we can continuously improve our sessions. And also you will receive the EACME certificate if you fill in the survey within 2 weeks' time. No many questions came in. Everybody thanked you. I would like to thank you as well, Arnout, for the interesting presentation. And yeah, I would like to close this webinar. Have a good evening, everyone.
Thank you very much. Good evening.
Good evening. Bye.